We're going to talk about, or Laura is particularly, but we're going to talk about the La Sala, Santa Fe County's La Sala Crisis Center. That's located off of Galisteo Road, a little bit south of St. Michael's Drive. It's co-housed in a building with the Santa Fe Recovery Center. That's a facility that actually we, the voters, approved with a $2 million bond issue, I believe, in 2016. So it's a big deal that the voters supported that effort to beef up the county's presence and involvement with behavioral health treatment. And then the county commission ended up passing a small gross receipts tax increase to pay the operating costs of operating the facility that Laura works at. So with that quick background, I'd like to introduce Laura Murphy. Laura works for a firm called New Mexico Solutions, which is on contract to Santa Fe County to run the La Sala side of the building I just mentioned. And Laura's going to talk about basically what La Sala Crisis Center is all about, and also how the city and county's alternative response unit and mobile crisis response team units that are integral to having people who are in need be brought to La Sala and what that's all about. And Laura is fine with, if you have questions along the way or something doesn't make sense or you think of something, she's fine with being interrupted either in the chat or just raise your little yellow hand down there. I think it's under reactions, and we'll call on you and get your question answered during Laura's presentation. And so with that, welcome, Laura. Thank you so much for being a part of our forum tonight, and take it away.
Thanks, Craig. Hey, everybody. I'm Laura. Thank you all for allowing me to participate in your meeting tonight, and I'm really excited to be here. And I will just jump in. And as far as the questions go, if somebody, I'm not very good at noticing stuff popping up in the chat when I'm also trying to just concentrate and say what I want to say. A little too many multitasking tasks just sort of overwhelms my capabilities.
Yeah, Laura, don't worry about that. Jessica and I will keep an eye on the chat and on the hand raising, and we'll interject when we need to.
Yeah, please do. Thanks so much. Okay, great. Okay, so let me see here. I'm gonna share my screen, and can you all see my screen?
Yep.
Yeah. Okay. Now I shall. Let me see.
I think you can go to the slideshow. It's like 1, 2, 3, 4, 5 over on the menu.
Thanks. Yeah, the bar here is sort of covering that, but maybe I can get my bar to disappear so I can. Let me just, or maybe I can just X out and try sharing again. I think I will. I know what I'm going to do. I will. Where'd it go? I lost it. Sorry, everybody.
No problem. It was certainly workable the way you had it, Laura, if you don't get it to be full screen.
Oh, okay. I think I will. I'm reopening my PowerPoint, and I think what I can do is I'll click that first, then I'll get in here and share the screen. Maybe. What happened? It totally disappeared.
I can also
Yeah.
bring it up, Laura, if you want me to. I'll just
Oh, here we go.
I'll just okay, good.
Okay, yeah, sorry everybody. Okay,
Mm.
cool. I'll just I can't seem to get the bar to move.
That
so
works
I can-
fine the way it is.
Okay, cool, rad. Okay, so yeah, so La Sala is the building that we occupy. I work for Santa Fe Crisis Triage Center, and there are actually several CTCs, Crisis Triage Centers in New Mexico. There's Bernalillo, and there's one in Las Cruces, and then there's us. And so it's pretty exciting, you know, to see these centers popping up in the state. And so yeah, La Sala is it's kind of confusing, but La Sala, the idea of the living room model of it in that, and it does refer to the crisis center, but the building is actually called La Sala. And so we're half the Santa Fe Crisis Center, and the other half is the Santa Fe Recovery Center Detox. And we're at 2052 Galisteo Street, and our number is 505-819-3419. And we do actually have a 24-hour crisis intervention service that when we're not open, that if anybody were to call in crisis, they would be directed to this particular intervention service that, you know, is answering our calls all night long. And so that's really cool to have that service as well. In this particular slideshow, most of it was put together by our director, Kate Field, which I'm sure many of you know. And she was going to try to be here tonight, but was a little bit busy with other projects and not able to join. But she said to say hello to everybody and to thank you for the opportunity for us to be able to come and share with your group. And so I'm sure many of you are familiar with Maslow's hierarchy of needs, so I'm not going to go into a big discussion around all of that. But, you know, basically the idea behind the crisis center, and I would say, you know, behind probably the objectives of most providers who work in behavioral health. I'm hoping that the idea is that we understand that we have to work with people and meet them where they're at. And, you know, and part of that is in recognizing that, you know, many of the folks who are experiencing a behavioral health crisis have a whole lot of overlaps that are going on along with that crisis, you know, such as maybe, you know, not having any you know, secure food sources, or not having a place to live, or you know, a lot of different things with just getting those basic needs met, and connection and belonging, of course, and in community and support, and you know, access to education or things like that. So you know, the idea, I think, in what we're trying to do, especially from the case manager standpoint, which we have in our program, the idea would be to connect people who are having who come to us having a behavioral health crisis, to helpfully connect them to ongoing resources that will meet some of those other needs beyond the mental health, or if there's a substance use issue going on beyond treatment. So but some of the history, and Craig was asking me to get into some of this stuff, and I don't want to, I might attempt to be somewhat brief, and then, you know, just where there are questions, then just please, you know, jump right in. But so basically, we have, through the city fire department, we have the mobile integrated health office. It used to be MIHO, and through the mobile integrated health, we have the alternative response unit. And so they were actually created to go out into the community and to create a very just a very friendly team of approaching folks who are either maybe living on the streets, or just, you know, are frequently on the streets, or and to try to build relationships with those individuals. And another main objective with the mobile integrated health office was to specifically provide support for folks who were experiencing overdoses through opioid use. And so just trying to you know, to provide support and connect those individuals with resources and with harm reduction supplies, and education and opportunities for um, just, increasing their well-being and hopefully increasing their access to services that might, support them with whatever their goals, whatever their goals may be. And so the alternative response unit is a really, really wonderful um, team that we collaborate with. And of course, they're a very nimble team because they have individuals, who are trained paramedics, and so they have access to 911 CAD systems. So when there's any kind of a 911 call, the ARU is constantly looking through those calls as they come in, and they're catching the calls that are specifically related to um, well, a lot of times non-emergencies, but not always, and many of them being behavioral health, and just they're just trying to find certain calls that might not necessarily be calls that police would have to intervene. Although police are often partners with the ARU too, so it's always just case by case. And so, but the alternative response unit, so yeah, their team consists of a paramedic and a case manager. And so what was lacking within this immediate response service was a little bit more experience or expertise maybe with just with a licensed therapist. And so they created the mobile response team, or the MCRT, the mobile crisis response team that we operate. And so we collaborate with alternative response unit when they find somebody who's having a behavioral health crisis, and then they will activate our team 24/7, 365 days a year. And we go to that community member on the scene and work with them to meet that person's needs. And
Laura, I've got a
yeah,
quick question. You mentioned
yeah.
911, and 911 is creates a lot of the referrals to the alternative response unit. I presume also, now we have 988, which is the behavioral health crisis and not crisis helpline, if you will. I presume a lot of the 988 calls end up going to the alternative response unit and creating referrals also to a Sala. Is that correct?
Well, there is some of that. We do end up mobilizing and going to scenes where that person had initially made a 988 call. That does happen, but it's not as coordinated as you might think, actually. And that's something that we're going to be working on, and it's just going to take some time for all of that to be developed. But yeah, that does happen for sure. If it turns out that someone, when they call 988, if 988 intervention specialists do find that they need to be referred to 911, or usually those call responders will have to call 911 themselves, then yeah, the ARU could get involved in that. We might be involved. It really just depends on the context of the call. And
Okay, thank you.
yeah, thank you. And so, yeah, so here's some information on the Santa Fe Crisis Triage Center. So yeah, we are an immediate low barrier crisis intervention support. We, at the center, we operate a walk-in center, and that would be for individuals who are 18 or older. And yeah, it's totally free. We do not have to collect insurance or anything like that. It's a really, really safe program for even individuals who may be undocumented, who are needing immediate support. And so yeah, we have a lot of different services that we offer. We've got 2 respite rooms, and those rooms can be utilized by individuals who, if maybe it's their first time and they're not quite ready to engage in services, but they just need a place to de-escalate and rest a little bit, and we'll help them with that. We'll give them a shower, and if they need to wash their clothes or even get a change of clothes, or we provide hot meals, lunch and dinner, but we also have some hot breakfast items as well, and snacks throughout the day when people come and go. And so, but then we have case managers, and we have licensed therapists, and we have a peer support worker, certified peer support worker. And that's Craig, going back to Santa Fe Recovery Center, and everybody, but Craig had just mentioned Santa Fe Recovery earlier. That's where we can do a lot of collaboration with the Detox Center, and we do. Our certified peer support worker is able to do, and she's very, very connected with Santa Fe Recovery Center and has a great history of collaborating with them. And so she's able to call and kind of, find things out and try to organize getting the coordination for someone to get a bed as soon as possible. Or sometimes we end up having to transport that individual to the hospital, and sometimes that can be a good strategy for getting into a detox bed. It just kind of depends on what's going on. It kind of depends if it's the weekend or whatever. But we can't directly get people into the detox program, which I think might have been one of the ideal objectives behind, us being in a building. But it just, in real time, and the way it all works out, it just didn't work out that we would have that kind of leverage, unfortunately. But we do have a pretty good leverage, and we can usually get people in. And we've been able to do a lot of really cool collaboration with the Santa Fe Recovery Center, and working with individuals who were having any kind of sometimes having a medical crisis that needed to be seen by one of our nurses first, and then we were able to get them in, or maybe even get them to the hospital. So there's been some really interesting collaboration that I think has been really helpful to community members in that regard. And
I have a question.
yes.
Before you leave this chart, what kind of support do you provide for families and caregivers? I know we've talked about NAMI collaborating with you for family support groups, but is there something else you guys provide?
So what we could offer to NAMI families, is that what you mean?
Or anybody in the community, any family member that comes in, maybe with bringing in their loved one, what do you guys provide as support for the families or caregivers?
Yes, that's a great question. And so definitely we provide a lot of support, therapy, case management to family members as well. Basically what ends up happening is that family member can become a client as well. Like if they would like to engage in any kind of services, like just being able to talk to a therapist whenever they might find themselves to be in some level of crisis, and they can't maybe get in to talk to their own therapist, because of course all of that takes booking and this and that. We're a wonderful resource for anybody who's going through any level of a crisis, if that's just simply being in crisis because of what a loved one is going through. Absolutely. And, if we can provide any case management or connection to other kinds of resources that can also be of support to family members, we will do that as well, like helping that person find support groups, or checking in to see with that family member, how are you doing on food, are you getting your basic needs met, and so we would be able to refer that person for services as well. We can also just be a place for respite and de-escalation for that individual, and that's happened quite a lot when someone is just under a lot of stress because of the crises that their loved one is going through. They've come in to just have a place to talk and have had lunch, or we'll have a cup of tea and coffee and just be able to have a place to touch down and check in. And so we're happy for the crisis center to be used in that way as well.
And you part of the Connect navigation? Are you navigators on the Connect program?
We are, yeah. So we will refer people through Connect and using the Unite Us database that Connect operates.
Okay.
We don't receive referrals through that though, because we just do not have the staffing or the capacity to receive referrals in that way. So basically a referral would be an individual who got information like from your group or from the LifeLink or, from the ARU or whatever, and they choose to walk in the door and get services. And
Okay.
they could, yeah, does that answer your question?
Yes, thank you. Thank you, Laura.
You're welcome. And
Laura, another
so-
quick question.
Sure.
What is meant by a low barrier crisis intervention? What's low barrier mean?
Thank you very, very much. That is an extremely important question. And so low barrier is going to be an individual who's maybe experiencing a psychotic episode, who's currently, experiencing a psychosis. That could be a person who is maybe even intoxicated. Now, when it comes to being intoxicated or maybe experiencing a psychosis, we do need that person to be able to just to be able to fully consent to the service, right? So if their psychosis is so severe that they're absolutely unaware of what's going on, or very, very disconnected from the reality of the situation, we would likely want that person to get stabilized at the hospital first. But we would be able to work with that person once they're more stable and can come in and consent to voluntary services, because we never, well, you know what voluntary means. We don't force anything on anybody, and people are able to come and go as they please. Low barrier could be someone who is chronically unhoused and has a multitude of various issues going on with substance use or even legal issues. Where we're a place, we're trying to be a place that helps to mitigate some of the traffic that goes into the emergency department and departments at the hospitals. And so the idea is to try to create a place for individuals to go to if they don't actually need to be medically stabilized first, which many actually do. And does that answer your question?
Yeah, thank you.
You're welcome. And low barrier can also mean there can be, and many of the individuals that we work with are struggling on multiple tiers in their lives, and they don't have access to other services anymore, maybe due to behavioral stuff or due to exhausting resources. And Santa Fe's a little town. Like it doesn't take long sometimes for certain people, especially that have really high needs and are really, struggling on multiple levels, to exhaust resources. And that's really unfortunate. But usually when that happens, it's typically around behavioral stuff or just not being able to follow rules at various organizations, enough. And so we try to be a place where individuals who maybe don't get access to other services anymore can still come to us. And we're always working on being the type of safe and open place where everybody can come in. And maybe somebody who's just out of jail and needing some support, we definitely can work with some of those individuals if they identify as also having a behavioral health crisis going on. So those are some of the low barrier examples. And I want to say just props to the team. Some of the folks that we've been able to support, some of our community members are extremely are living with extremely impaired experiences. I don't know, like with mental health, and have gone to a state hospital or been incarcerated a lot, or have been in and out of treatment, who are chronically unhoused. And we've been able to do some really big work with some individuals who have had decades long struggles. And we're really proud of that. And we do a lot of big work with those individuals, especially when they have been high utilizers at the emergency room. A lot of times, unfortunately, it can happen that some of the high utilizers don't get their needs met when they continually go to the emergency room. And not to fault the emergency. I don't even want to really go there. That's like a whole other thing. But so what we do is advocate for those individuals, and we will go and sit in the emergency room and go and get them connected with crisis counselors and in the emergency department, and do what we can to make sure that those individuals get the care that they need. And so, yeah, so it's a walk-in access point for navigation with our therapists and our case managers collaborate and come up with a, very customized treatment plan per individual as they come in. And they walk in with, usually it's more than one crisis because, humans are complex like that. And so we try to work with all of those different layers of crises that are going on and come up with some pretty quick triaging to try to get those individuals the care that they need. And there's another slide that's going to talk a little bit more about our medical program, but I'll say one of the other things we offer is that we do have medical staff, and we take vitals, and we assess if somebody's even safe enough medically to be able to be at the center, and if they're not, then we would coordinate to get them to the hospital, and then coordinate with hospital staff to then, upon that person's discharge, to then come back to us. And so that does actually happen quite a bit. And other stuff that our medical team can do is we've got a nurse practitioner who's available through telehealth, and she is able to meet with clients and connect clients who do not have doctors with temporary medications. And that's been really, really effective, especially for individuals who are waiting for months to get to their new doctor, but are experiencing some kind of chronic issue that needs medication now while they're waiting. So we try to fill those gaps and connect that, create a bridge for that individual until they can get to their ongoing provider. And also, if somebody doesn't have a provider that they're planning on seeing, we do a lot of referrals and try to get people connected to ongoing teams and ongoing services. And so our other service is any other questions on the crisis center? Just on that, we'll keep going. There'll be more. There's so much. It's really a complex program. And then our other operation is the mobile crisis response team. And so we kind of went over with that, when we were discussing the mobile integrated health office and their alternative response unit. So our team is a little bit different than the ARU because we have a case manager, peer support worker, and a therapist. And so we're sort of able to fill that need when a 911 first responder of any kind shows up and it's clear that somebody's having a behavioral health experience and that they're needing support and just a little bit more expertise, a little bit more assessment of the possible dangers somebody may be experiencing, or if it's something that could be handled, and then referring that individual the next morning to then go to the crisis center and be able to get in the door and get assessed and become a client if they'd like to, and their family members as well. And so, so mobile crisis response team goes to any community member within the Santa Fe County area. So it's pretty big area that we cover. And we do respond 24 hours, 365 days a year. And so I'll go ahead and go to the next slide. And I already really discussed this, so I'll kind of just move on. But I do want to mention that our slides, if anybody wants them, I've given them to Jessica, and you all are totally welcome to have access to them if you just want to get in there and really read it more. But I really am actually covering all the details, but please feel free to have slides at hand for your own reference. And so, the community response. This is kind of some of the stuff I've already really covered. That the psychiatric issue is really a big part of what is a gap that we're filling that's really, really important. Because, you know, individuals like it, and we work a lot with the Lifelink and other agencies where individuals are needing, you know, access to psychiatric medications and they're just not able to get them quickly enough. And that's one of the major services I think that we fill, that we're working hard to really develop and to expedite in a, you know, very seamless way, although it's not always seamless, but we're trying to be able to make that move very quickly, get people seen, get them their meds as quickly as possible. Another thing that we do from the psychiatric and the medical side is um, we've been able to work with clients in administering their Haldol shots and in any other shot that needs to be injected, you know, by a medical provider. And that's worked really well. So that individual may bring their medication to the nursing staff, and our nurse manager will administer that. And or, you know, we've been able to help people by taking them to the pharmacy, helping them get their medication filled, taking them to the pharmacy to get it, bringing them back to the center, and then administering it. We can't hold anybody's medications for them, but we can help them get it and help them administer. And so that's been a really effective part of our medical service as well. And I don't know, this is really great. If you would like the slides, you're totally welcome to go through and look at that a little bit more. But yeah, so we also work with the county sheriff's office and through a jail diversion program. And so basically we can support the sheriff's office and their case managers who are working to help keep folks, you know, from moving in and out of the jail revolving door, and to try to figure out other opportunities for that individual. And so, you know, specifically just by providing a place for folks to go and get support and de-escalate. And that's been an effective part of that collaboration. And we can we just continue to keep trying to fill in the gaps. And some of those main gaps, like I said, are for individuals who their needs are so high that there really aren't a lot of services for them, which is really sad. And I believe the state is working on trying to create more opportunities for individuals that are struggling, you know, at that level. And you know, those services have got to be created. And we're all aware of the lack of resources for certain individuals. And so we can fill the gap to some degree for the individuals where there really aren't any services for them. And those individuals, typically the services that they really need don't exist. And then what they have access to, a lot of times they're not able to manage it on their own. And so, like, get to their own appointments, set up their own appointments, communicate and advocate for themselves. So we can do a lot of that. And we do a lot of that for those individuals. And we show up in court and we advocate for those individuals, and we go to the hospitals, like I said. So that's been really effective. And that's some of the work that we're the most proud of, for sure. And yeah, if they don't meet the criteria for inpatient care, which is a whole issue that maybe, you know, they should meet those criteria, but a lot of times they don't. And when those individuals don't meet that criteria, what's going to happen to those individuals? And we work with those folks a lot. And yeah. So we've just found, yeah, that, you know, the public safety agency coordination, this whole list, these are all the different activities and agencies that we are doing or coordinating with, and all of this is working. And these are all the aspects of person-centered care and just, continually being available for folks to walk in anytime that they need help. Like all of that's working really, really well. And we just got to keep developing our program. We'll be developing our hours of operation. We're currently open Monday through Saturday, and we open at 8 a.m. And depending on staffing, we are at least open until 6 p.m., but we typically can at least manage to stay open until 8, but eventually we'll be a 23-hour operation. And that's meant to be a 7-day-a-week, 23-hour operation. And we'll get there eventually. It's just going to take time to build it. And so these are some of the support groups that we have available, and they are free and open to our current clients. So it has to be that the person who shows up for the group has already been assessed, and it's already been incorporated into their treatment plan by the therapist who created their plan. And so we've got Seeking Safety on Tuesdays at 11 o'clock, and that's for folks who are recovering from substance use and trauma or PTSD symptoms. And as it says here, the group fosters awareness of triggering situations and tools to manage these situations. And we've got our addiction recovery group on Wednesdays, and we call it that because it's modeled after SMART recovery, but it's not exactly SMART recovery. And so, the self-management and recovery training. And so we operate from the more science and evidence-based program, but it's still a great fit for anybody who, likes AA and NA and the 12 steps and more spiritual programs. Like that is totally welcome. We are working on bringing in I think it's Recovery Dharma. And that could be another opportunity for folks who are interested in, a program that utilizes the Buddhist concepts for relieving suffering and practicing meditation and things like that. And but it does have a focus on not just substance use, but also process addictions. And so that hasn't been set up yet, but I'm hoping that's going to happen. And we have our sensory wellness, which is going to be, like it says here, developing awareness and social and coping skills using music, art, and sculpture and other sensory experiences. And we're working with a occupational therapist to develop sensory centers for to provide opportunities for self-soothing and engagement with various kinds of sensory stimulating neat things, and all of that is actually coming really close to being fully operational at the center. And it's really exciting stuff. And then you'll see over here on the right, there's my name and my phone number and my email, which you're totally welcome to take down. And I have been the lead case manager and am now community liaison. And I was also on the mobile crisis response team, so I have a lot of experience in working with first responders and community members. And I also facilitate via Zoom these days. I would prefer in person, but I'm working remotely currently. But I do facilitate a mental health first aid class, and can give that to providers or really anybody who's interested in that. And that's about it. Does anybody have any questions or need any elaboration on anything?
I have a question, Laura. Can you hear me all right?
Yeah.
Okay. Yeah. So I had a question about, and thank you so much for your presentation. I had a recent person who needed services but didn't necessarily feel that they were in crisis at that moment. What they needed was food services and some medication management, and they just needed an entry point. So we did end up referring them to La Sala. They had a really good experience, and it was a really good entry point for them. But I just wanted to just make sure that it is okay to refer people who may not, be experiencing a psychosis or anything like that, but are just looking for an entry point for services.
Yeah, definitely. That to me, if somebody has a few different things that they're needing help with, that is a kind of a crisis, you know? And so, but yeah, there are obviously different levels of crises that a person can experience. And yes, a person does not have to be, you know, fitting within that like the low barrier services, you know, and or for that, that is absolutely not necessary. That anybody who is needing help or needing a place to touch ground or needing to speak with somebody, they are all absolutely welcome.
Wonderful. Thank you.
You're welcome.
Jessica took my question, or
Sorry.
no,
It's a
that's
different
good.
version.
And that's something I was concerned about, is that there's a lot of people in our community who are struggling with alcoholism or drug addiction or depression or anxiety, but their situation doesn't reach the level of what most of us would consider to be a crisis. And I know I've been there a number of times with moderate to severe depression, where I wasn't a danger to myself or others, and I didn't consider myself in crisis, but I needed help. And so it's really good to hear that La Sala or the Crisis Center can accommodate people like that. My only concern, and I shared this with Rachel O'Connor, with the County Community Services Director, is my concern is that without clarifying that you don't need to be in crisis to go to the crisis center, it might be a little bit intimidating for somebody who doesn't really consider themselves in crisis. And so they may not ever pick up the phone and call the crisis center because they're like, oh, that's not for me. That's for someone who's on the verge of overdosing or is suicidal or what have you. And I think it might be helpful to try to clarify that in some of the outreach materials, that you don't have to be truly in crisis to take advantage of the wonderful services that the Crisis Triage Center happens to offer.
That's a really great point, and I will just pass that on to Kate. I really appreciate that suggestion for just, you know, kind of edging that in, getting a little bit more language on that area. And because that it's a great point, because I think that there could have been more of an understanding or maybe an intention by the county that this particular program would not be so well, we're highly focused on individuals who are chronically unhoused, who are experiencing psychosis, who are suicidal, who, you know, like really, really, really intense experiences with behavioral health. We tend to be working with those individuals, partly because those individuals often don't have their resources lined up, and also because they, you know, the nature of a crisis is very spontaneous, and we all know it's really hard to see your doctor just any old time that you know that something happens when you really need that doctor, but you can't get in. You know, it takes months to get in to see a doctor sometimes. And so yes, it very much, like, I think there was, you know, part of the planning for La Sala was to be to have more of individuals from different populations in Santa Fe County coming in, but it's been that most of the individuals that we see are typically experiencing many really extreme situations, you know. And but I like what you're saying, and I'm going to pass that by to Kate and see if we can try to just get a little bit more language that's a little more helpful,
Yeah.
that invites everybody.
That's great, thank you. And that's very similar to the 98, the relatively new 988 number, that a lot of times it gets confused or marketed or presented as a crisis line for overdoses or suicidal ideation or what have you, when it's clear from the 988 materials, when you dive in deeper, that it's really for anybody who's struggling with a behavioral health issue.
That's right. Mm-hmm.
So.
Yeah, I think that and I have talked with people when they called us to talk with us during the day, and their understanding was that, you know, that 988 was more around support for folks experiencing suicidal ideations of some kind. And my understanding is that it was, you know, it's really a support line 24/7 for anybody who needs somebody to talk to about anything.
Yep.
So.
Yep. So thank you for that. And I see that Betty has her yellow hand up, so we'll call on Betty.
Well, Jessica had her hand up first, so I'll let Jessica
Oh,
go.
there's Jessica. Okay.
And it's actually not me, it's on behalf of Tom, who's right
Oh,
here.
First of all, thank you, Laura, for the talk. It was really, really great. My question is just, have you seen an impact from COVID in the people that you served? And if so, can you talk a little bit about that impact?
Oh, wow, interesting. Yeah, so are you seeing, sir, an impact that the pandemic caused a behavioral health experience for those individuals, and they're now coming in to deal with the trauma that came from the pandemic?
Yes.
Yes, okay. Yeah, I don't have any numbers on that, but I definitely think that that's completely, that so many people, that their crisis is enmeshed with the trauma that they experienced through that, if it was from isolation, which was obviously, very common for many, many people. And, and I can say on that note, actually, when we've worked with seniors in crisis, especially closer to our doors of the center opened in August of 21. And so definitely closer to that time period, many of the seniors that we worked with actually were, and some of the calls that we went on MCRT when we were finally up and running once it was deemed safe enough for us to go out. Many of the seniors were definitely dealing with trauma around isolation from the pandemic. And I'm trying to think of other examples, but yeah, I don't have any statistics, unfortunately, but I think yes, definitely. That's been major for various people. And also because also part of our low barrier program was that we never required anybody to be vaccinated to, or to show any sort of proof of vaccination or anything like that. And yes, it was very common that with many of our clients, it was very common that many of them had a lot of fear around vaccination. And it was really unfortunate for those individuals, especially if they're chronically unhoused, because there were no services available for them because of their decision to not be vaccinated. And many people felt discriminated, and that increased their level of distress, of course. And that was a very trying time, especially for those folks, I think.
Thank you very much.
Thank you.
Betty, and then we have a question from Tina in the chat.
Yeah. Again, Laura, thank you for some of the clarity you provided on the La Sala, the Crisis Triage Center, the Detox. There's been a lot of confusion about, like you said today, La Sala is the building. Well, we call it the La Sala Center or Mental Health Center.
But may I just jump in real quick?
Yeah, go ahead.
I want to just say that that's how it's unfolded. That was not how it was intended, and so that's why the confusion is there.
Right. Yeah,
so,
we've heard it named lots of different things, I think, as we watched it, start up and progress. And then the other issue between how the ARU gets dispatched versus how the MCRT does. There's been some confusion about that and whether you can actually call the ARU or the MCRT directly. I know you can call your center directly. I know that. And then I guess you guys dispatch from there, or 911 dispatches. But there's a lot of confusion in the community. Even in my mind, there's a lot of confusion, but that's just probably me. But the other thing I wanted to, but thank you for clarifying some of that. That did help. So the only other question I had was, in terms of your working with the hospital, with the emergency departments, do you just, I know you said sometimes you take clients to the hospital. Do you take them to Christ St. Vincent, or do you go to Presbyterian, or do they send people over to you? How do you collaborate with the hospitals?
Yes, thank you very much for everything you just shared. Yeah, we do take individuals to both Presbyterian and Christus. Now, if we're working, I mean, most folks do end up going to Christus. And I think there are a few different reasons why that happens. But we do work with both hospitals, and we mostly receive these days referrals from Christus Behavioral Observation Unit. So, and also, the behavioral health unit, if somebody does go into any, amount of hospitalization, from the BOU, then we will get referrals from that department as well.
But not from Presbyterian?
Referrals from I mean, I'm sure that we do. It's just definitely more from Christus. And I don't know the exact reason why. I think part of it might have to do with because when individuals go to Presbyterian for a behavioral health crisis, and if they are admitted and hospitalized, then they go to
Okay.
Albuquerque.
Yeah.
So I think it might have something to do with just locality and structures of program and things like that. But we definitely do, and more because I've been on the team. I've actually the longest member of the team. I've been on the team since day one of inception, and I do remember way back earlier on in 2020 we were doing everything was telephonic, and we were working really hard to connect with NCOs and in the different hospitals and stuff, and we were trying to do a lot to build partnerships with both hospitals, and so there was more conversation going on with Presbyterian. So I'm not sure where all of that stands right now, but just be assured we are always trying to build connections and collaboration with both hospitals. And so, but then of course, wherever all the actions coming from tends to take up all of our time, because it just, that's where we end up focusing. And but we're doing big work with Christus currently for sure, and that's going really well because and it's just interesting because as staffing changes at a place, that can change, the nature of collaboration and the nature of communication. When you do a lot to build coordination with individuals, and then all of a sudden, or little by little, the staffing changes and kind of all falls apart, and then you have to rebuild it, that kind of thing. So it's just an ongoing process in that regard.
Okay, thank you. Thank you.
Sure,
Yeah.
sure. I wanted to speak to the confusion on if there's time. I see that it's 7:01.
We have a little bit of time, Laura.
I'm sorry?
We have a little bit of time, sure.
Okay, sure. I'll be really quick on this then. Just speaking to the confusion on mobilizing, I know it's totally confusing. And part of the reason why it's totally confusing is because there have been various programs and there have been various structures, and then they change, and the rule changes, or what can be, it's totally confusing. But where we're at and where we have been for a while now is that our mobile crisis response team can only be activated by first responders who are activated through a 911 call, and then they go, police, paramedics, they show up, or the ARU. If it's during ARU hours, they only work limited hours during the week and during the day till like 5 p.m. or something. But those entities, sheriff's office, if they county fire, if they mobilize through a 911 call, and then they want our support, then they would call the regional emergency call center, and then our ECC would then activate us, would mobilize us. So basically our service is more about supporting the first responder who is supporting the community member. We are not available to be mobilized by community members calling us, and that would be really, really wonderful. But the unfortunate reality is that we need often for there to be the presence of a law enforcement officer, for protection for staff members, especially if it's in the middle of the night or something like that. Like, we just cannot just show up at a person's house because there's a crisis going on. Like, there has to be some structure for safety. And that's we've had to come to that over a lot of trial and error and things like that. And so that's how that works. But yeah, we are definitely available. Our main line is our main phone number is available for individuals if they want to call and ask questions, or maybe they need to talk. A lot of times we can even get our therapist to call somebody back if they're not able to get to the center. We try really, really hard to accommodate people who, are not able to walk in or not quite sure, and they're just, needing to check it out a little bit, feel, find out if they feel safe and if they want to come. We try really hard to work with folks and meet them where they're at with that. And um, and then of course, like I said, we've got that 24-hour line. So for folks, like if they call us and they need to talk to somebody and they don't want to call 988 or don't know to call 988 or whatever, they would call our number and would immediately be connected with a crisis intervention specialist.
Great. Thank you, Laura. We're basically out of time, so I want to thank you, Laura, so much for presenting to us tonight on such a critical program in our community.